Welcome back to the deep dive. Okay, let's talk about that moment. That sudden, really sharp pain deep in your side, your lower back. And your first thought is sheer panic.
Oh, yes. Is this, just a terrible muscle thing, or is it serious? Like, my kidney.
Exactly.
Yeah.
It's terrifying because you just don't know. Complete confusion.
And it's a scenario doctors see constantly. It's very common. The confusion makes total sense, really, because the pain zone is identical.
Right. Whether it's muscle or kidney, it feels like it's in the same spot.
Precisely. So our goal today, our mission for this deep dive, is to bring some clarity. How do we actually tell the difference between real kidney pain and pain coming from, say, the spine or muscles nearby?
And we'll start with that first check, the physical test that can quickly point towards the kidney.
Yes.
But then, assuming it's not the kidney, we're diving into the main suspect, this
Yeah.
really powerful muscle that's, well, a master impersonator when it comes to pain.
That's the plan. So first
Yeah.
things first, spotting a potential kidney issue. There's a pretty standard clinical maneuver. It involves finding the right spot over the kidney area, the costovertebral angle, and then giving it a light tap or series of controlled gentle thumps. It used to be called fist percussion.
Gentle thumps, okay.
Yeah.
And what does that tell you?
Well, if the patient reacts really strongly, like with sharp, severe pain just from that light percussion, that points pretty strongly towards a kidney problem. And that means, time to see a nephrologist, get it checked out properly.
Okay, so that's the initial sort out for genuine kidney distress. Makes sense. But let's say that test is negative, which you're saying happens a lot with this kind of side or flank pain.
Oh, absolutely. The majority of cases presenting with this severe flank pain don't show that positive kidney sign.
So if it's not the kidney,
Yeah.
where on earth does pain that intense come from?
Then our focus shifts immediately. We look at the musculoskeletal system, and the prime suspect is a muscle called the quadratus lumborum, the QL.
Quadratus lumbar, okay.
It's not some small surface muscle. It's deep, quite thick, pretty rigid, actually, running along the sides of your lower spine.
So deep inside there.
Yes, from the top of your pelvis up towards your lower ribs. It's right up against the lumbar spine.
Sounds like it's in a really critical spot structurally.
It absolutely is. The QL is a major support muscle for the whole lower back. It's in, well, what we call intimate contact with the spine itself.
Intimate contact, okay.
And when that muscle gets seriously dysfunctional, it can mimic kidney pain almost perfectly. It's often the first thing patients think it is.
Right. Okay, so before we get into how it causes pain, maybe just quickly paint a picture of that area. We've got the spinal bones, the vertebrae,
Yep, the vertebrae stacked up, the discs in between acting as cushions.
and the nerves.
Crucially, yes, you have nerve roots exiting from the spinal column, especially down in that lumbar region. They come out the sides.
And those are the nerves going down to the legs, right?
Exactly. And that whole setup bone, disc, nerve root muscle is key to understanding this QL problem.
So what goes wrong with the QL? It's not just like a simple cramp.
No, not at all. We're usually talking about something more severe, like a retraction or an intense locked-up rigidity.
Retraction, meaning it gets shorter.
Yes. A healthy muscle needs to be elastic, right? Able to stretch, contract, relax. But when the QL goes into this state, it shortens dramatically. It gets incredibly tight, rock hard sometimes. It becomes completely dysfunctional.
And if this super tight, rigid muscle is sitting right next to the spine, where those nerves are coming out.
That's exactly the mechanism. That shortened, tight QL muscle literally presses on those nerve roots as they exit the spinal column.
Ouch.
Yeah. And that compression is what causes the severe pain. It's musculoskeletal pain, but because of the pressure on the nerve, it can also radiate, which confuses things even more.
Okay, this is where it gets really interesting and frankly, a bit scary for someone experiencing it. You sometimes hear patients describe this pain vividly.
Oh, absolutely. The classic description, the one we hear quite often, is that it feels like a dagger stuck in the back.
Wow. A dagger. That sounds incredibly intense, sharp, piercing.
It is. It really grabs your attention. Usually felt deep in that flank area, the waist, or what doctors call the iliac fossa, that kind of deep dip.
So if someone feels that dagger pain, how do they know it's not an emergency, not the kidney? What are the clues?
Great question. While the pain itself is severe, the triggers are often different from kidney pain. A key clue for QL pain is that it often flares up dramatically with certain movements or efforts.
Like what?
Things that suddenly engage your core or change pressure in your abdomen, taking a really deep breath, for instance, or a sudden sneeze, or a cough.
Oh, okay.
That sudden pressure change makes the tight QL clamp down even harder on the nerve. You might see someone instinctively grab their side, maybe bend over slightly.
Trying to protect it.
Exactly, trying to stabilize the area because that sudden jolt of pain from the nerve compression is so intense.
Okay, that's a really helpful clue. The sneeze or cough trigger.
But here's probably the most crucial differentiator, something kidney pain generally doesn't do. QL pain changes dramatically depending on whether you're bearing weight or not. Your posture and activity level are key.
Right, that sounds like something you could actually test for yourself, potentially. Tell us more.
Okay, so QL pain typically gets worse when you're upright and putting weight through your spine, like standing for a while.
Waiting in line at the supermarket.
Perfect example. Or the bank, or even just walking for a bit. Standing and walking require that QL muscle to work constantly to stabilize your spine, so the pain ramps up.
Okay, that makes sense. More demand on the muscle means more pain if it's dysfunctional.
Precisely. And conversely, the pain tends to calm down or significantly reduce when you take the load off.
Like lying down.
Exactly. Lying down or even sitting often brings relief because the spine isn't bearing as much weight and the QL can relax a bit, reducing the pressure on the nerve.
That standing versus lying down test seems incredibly useful. A really clear sign it might be the muscle, not the organ.
It's often one of the clearest indicators that we're dealing with a musculoskeletal issue originating from the spinal support structures.
And you mentioned radiating pain earlier. Where does QL pain typically travel to? Does it stay in the back?
It often doesn't stay put. The referred pain, the pain that travels, commonly extends down into the buttock area.
Like sciatica.
Sort of, but often a bit higher and maybe more to the side than classic sciatica. Think slightly above where you'd typically get an injection in the buttock.
Okay, specific.
Yeah. So when you put it all together, the intense flank waist pain, the dagger feeling, the cop sneeze trigger, pain worse when standing walking, better when lying down, and that specific buttock referral, plus a negative kidney percussion test.
Then you're feeling pretty confident it's the QL.
Much more confident, yes. It points strongly towards column pain, as we sometimes call it, pain originating from the spinal structures, even though it feels like it could be the kidney.
Okay, so let's talk treatment. But first, you wouldn't just jump into treating the muscle without knowing why it locked up.
Right.
Does it just happen randomly?
Good point. No, it usually doesn't happen randomly. There's often an underlying cause, a reason why that muscle went into chronic retraction or rigidity.
Like what kind of things?
Often it's down to biomechanics or habits, things like sitting for really long periods, especially with poor posture.
Guilty?
Or maybe carrying heavy things unevenly, like always having a heavy bag or briefcase on the same shoulder.
The body tries to compensate.
Exactly. The QL on the opposite side has to constantly contract to keep you balanced, and over time, it can just get stuck in that shortened, tight state. So yeah, identifying and addressing that underlying habit or postural issue is really important for long-term relief.
Right. Otherwise, the problem might just come back.
It's much more likely to.
Okay, so let's say we've got the diagnosis. It's the QL, maybe triggered by poor sitting posture. What's the actual treatment path? How do you get that muscle to, well, unlock?
The goal is definitely to restore its normal length and elasticity, get it functioning properly again.
So stretching it out.
In essence, yes, but it often requires specific techniques. First, we confirm the diagnosis, maybe just by feeling the muscle palpation, sometimes imaging like an MRI if we suspect something more complex is going on.
Okay.
Then we move to therapies. Often it's a combination. Hands-on manual therapies are key.
Like massage.
Yeah.
Or something else.
It can include deep tissue work, but also things like osteopathy, maybe chiropractic adjustments to ensure the spinal joints are moving correctly, and specialized techniques like myofascial release to target the connective tissue around the muscle.
Okay, so hands-on work.
Yes, but because the main issue is that the muscle is too short, too retracted, we often need therapies focused specifically on elongation.
Making it longer again.
Right. And one very effective way to do that is with musculoskeletal traction.
Traction, like on those medieval-looking rack things.
Not quite like that anymore. Modern traction uses specialized tables. They apply a very controlled, gentle pulling force. The idea is to gently separate the vertebrae slightly and stretch that tight QL muscle, giving it space to relax and lengthen. It helps decompress the area.
So you're physically creating space to relieve the pressure on the muscle and the nerve.
That's the core idea. Restore the muscle's normal state, Stop it pressing on the nerve root. That eliminates the pain, stops the radiation down the buttock.
Makes sense. Now, you mentioned things can sometimes be more complex. What if the QL tightness isn't the primary problem, but it's tight because of something else in the spine?
That definitely happens. Sometimes the QL locks up as a protective spasm because there's an underlying issue, like a problem with one of the spinal discs higher up.
Like a slip disc.
Exactly, or a herniated disc, particularly discs higher in the lumbar spine, maybe L1 or L2, which are closer to the QL's upper attachments. If one of those discs bulges or herniates, it can directly irritate the nerves or cause the QL to spasm defensively.
So treating just the muscle wouldn't be enough then?
Likely not for long-term relief. In those cases, you need to address the disc problem itself.
And how is that done? Is that surgery?
Surgery is an option for severe cases, but there are less invasive treatments too. One mentioned in the materials we looked at is ozone therapy.
Ozone therapy. How does that work for a disc? I've heard of it for other things.
Well, for discs, it involves carefully injecting a specific mixture of medical-grade oxygen and ozone near or into the affected disc.
Okay. And what does the ozone do?
The main effect seems to be reducing the volume of the herniated or bulging part of the disc. It sort of shrinks it, partly through a dehydration effect.
So if the bulging part shrinks.
It physically pulls back from the nerve it was pressing on.
I see. So it removes the source of the nerve compression?
Exactly. By reducing the size of the bulge, you stop the mechanical pressure on the nerve root. This can provide significant relief, especially when the QL issue is really just secondary to that disc problem.
Fascinating. Okay, so wrapping this up for our listeners, the big takeaway seems to be that terrifying flank pain you fear might be your kidney. Well, it's very often this quadratus lumborum muscle acting up.
Yes, that intense, deep pain can definitely be muscular, even if it feels much more serious.
And the key clue you can maybe check for yourself is that difference with activity.
Absolutely. Remember that. Pain gets noticeably worse when you stand or walk for a bit, and then calms down quite a bit when you lie down or sit. That pattern strongly suggests muscle or spinal structure, not kidney.
Super helpful differentiator.
And it really highlights why getting an accurate diagnosis is so important. Is it just the muscle? Is there an underlying disc? A proper examination, feeling the area, maybe imaging. It lets us pinpoint the real source.
Right.
And that means the treatment, whether it's hands-on therapy, that specialized traction, or maybe even something like ozone therapy for a disc, is targeted correctly. You need the right fix for the right problem to really get that muscle relaxed and the nerve freed up.
It's all about matching the treatment to the actual cause. Makes perfect sense.
Precisely. Mechanical problems often need mechanical solutions.
So we've unpacked the confusion between kidney pain and this major muscle imposter, the QL. Here's something to think about as we finish. That QL is working constantly, stabilizing your lower back during so many everyday activities.
Yeah.
How much might our modern habits, hours of sitting, maybe how we stand, how we carry things, be contributing almost silently to that chronic tightening?
Yeah.
And what small, subtle shifts could you make before you ever feel that awful dagger in your back? Something to consider.